Urinary incontinence actually encompasses a large number of different types of leakage. The two most common types of leakage that I see is called urge incontinence and stress incontinence. Urge incontinence, if it's fairly mild, is just called overactive bladder. You may see that on the ads, for example, for medications. When the overactive bladder is severe, then the patient may leak. And leakage means that the bladder is actually overactive and it's a bladder problem. So the bladder says, I gotta go, and you can't make it. And that is treated, for example, different than stress incontinence. Stress incontinence means that when you exert yourself, let's say cough, sneeze, or even bend over in some cases, the pressure in the bladder is higher than the sphincter pressure, so leakage comes out. That is actually treated much differently. That actually requires surgery or some type of procedure to fix, whereas overactive bladder, urge incontinence issues are more of a medical treatment in most cases. As far as the diagnostics for those, and they can be complicated, but we normally start simple. And in general, that's going to require urinalysis. So for example, a patient has a urinary tract infection, you'll have overactive bladder. You may have to run to the bathroom, you may leak. So certainly we wouldn't want to miss something as simple as a urinary tract infection. I basically take care of almost just females. And I almost always do a pelvic exam because I almost always find something that relates to their diagnosis. So for example, patients who have stress incontinence will have a urethra that moves in most cases. In other words, you've had children, you got stretched, and so what happens is that when you cough or sneeze, the urethra moves and urine comes out. But in general, you can't damage or stretch the urethra without also stretching the bladder and the rectum. So they all kind of work together. So I normally do an exam to get an idea of the overall lay of the land. In addition, overactive bladder, the running to the bathroom part, can be due to, for example, a stricture, a narrowing of the urethra, which you can see on exam, or a mass. Although those are pretty uncommon to have cancer causing incontinence, it can happen. Prolapse of the bladder is really falling out very far, can actually bend the urethra, so it doesn't empty very well, and that can cause urge incontinence. So in general, pelvic exam is the second thing I do. Treatments, and we'll talk about those in a minute, don't work, then I normally will move on to more sophisticated studies, such as what's called a uroflow, where we have you urinate into a machine that measures the volumes and how fast you urinate, and then look at the bladder with a ultrasound machine to make sure that you're emptying. If those don't give us the diagnosis, then we can get a little more sophisticated. And the last two things that we typically will use in more complicated patients would be cystoscopy, which means looking in the bladder, and that's with the small scope. When we do that under local, some people are all concerned it's like a colonoscopy. It's much, much simpler, almost painless with local anesthesia, 3-minute procedure. And what we do is we look at the anatomy. We're looking to see, is the urethra have any tumors or anything weird going on? Say weird because there aren't that many things that will occur there. We also want to make sure, especially in older ladies, for example, they don't have bladder cancer or a stone. And I do see that on a yearly basis, so we don't want to miss that, of course. If the anatomy is normal, in other words, there's no tumors, there's no other anatomic things that are going on, then we have to look at function. And so, for example, like a car may look good but not run well, the bladder can do the same thing, and we perform a study called Urodynamics, which is a study in which we fill the bladder up with water and we see what kind of capacities that you have, is it overactive, and then we also fill you till you urinate, because some women are obstructed and we like to look at the pressures and how well you empty. So that's the kind of sequence of events as far as diagnostics for urinary incontinence, to look at any abnormalities that may occur. Once the diagnosis is made, as far as whether it's overactive bladder or stress incontinence, then there's really two different pathways of treatment. For overactive bladder or urge incontinence issues, we always start with medications and behavioral measures. So, for example, what I mean by behavioral measures is watching fluids. For example, we have some patients that come in to the office and are drinking a gallon of water a day. Clearly, that's excessive. And so normally I try to get them to decrease their fluid intake to 48 or 64 ounces, which is enough not to get dehydrated, because you certainly don't want to get dehydrated, or you also don't want to overdo it. Not holding urine. There's many patients who think that if they train their bladder by holding their urine, that it'll get better. It won't. And so the best thing to do is just stop what you're doing and go to the bathroom. And then lastly, some patients have trouble relaxing their their muscles when they urinate. And the problem with that is if you don't, then you won't empty all the way, which means you have to go more often. So those are just easy behavioral things you can do. And then of course medicine. All the medicines are directed towards calming the bladder down, giving you more capacity. So you have a bigger gas tank, and when you get the urge to go to the bathroom, the urge isn't quite as strong. And that's how all of them work. Now there is one that's a little bit different that came out recently, and it works slightly different, but they all are working towards the goal of increasing bladder capacity and decreasing overactivity. Let's say that medicine is given, patient comes back in a couple months and is not better. The next step will be to add a second medication. In other words, two working together in synergy. One of them has to be a medicine called Merbetric because it works totally different than the other ones. But that actually has helped quite well. And in fact, it's becoming, to some degree, standard of care for the next step after one medicine doesn't work. So let's say two medicines don't work. You can also add on something called nerve stimulation. And there's different methods of doing that, but the easiest method is a peripheral nerve stimulation. And it's very simple. Basically, you sit in a chair, and we use these electrodes to stimulate the nerves to go up the leg, called the posterior tibial nerve. The only problem with it is that it does take 12 treatments, and it's 30 minutes each time. And so that is a little bit of a transportation issue. I have patients who live far away that sometimes have trouble with that. If that does not work or is not possible, then you can do what are called Botox bladder injections. And I do a fair number of those. But in general, I try to reserve those for patients with fairly severe refractory, what we call medically refractory incontinence. And the scope of Botox is beyond our discussion today, but it is an option. Now, if you have leakage when you cough or sneeze, called stress incontinence, there are really three main ways of improving that. One is pelvic floor muscle training. And that is also an option, by the way, with overactive bladder issues, but in most cases, those patients are already doing that. But I do have a nurse, in fact, I have a whole team, but my nurse can train patients to get good at pulling those muscles together when they cough, sneeze, and do activities. However, it has some limitations, as you can imagine, but that is the first step. Second step might be a sling in a younger person, and there's different types of sling. There's been some bad press about mesh slings. That's a very complicated subject, but there are biological slings. In fact, probably at least half of the slings I do are not mesh. In general, that would be a long discussion, but in general, there are other things other than mesh, because some patients are quite concerned that they're going to get a mesh procedure, and they have the option. They make the choice, not me. And then lastly, for older ladies who, for example, may have health issues, there are injection therapies that you can use that are quite good. The only problem for younger people, and the reason we don't use them routinely, is they're not necessarily permanent. They only last a year or two. And so in general, we reserve those for older ladies who may have health issues and those kinds of things. But all of those are available for stress incontinence. Lastly, one of the things that I oftentimes find when I do exams on patients who have stress incontinence or any type of incontinence, a certain percentage, and probably 15%, will have what we call significant vaginal prolapse. In other words, the bladder is coming down. And in fact, I probably see that on a daily basis, seeing 20, 25 patients a day, because many patients don't even know they have it, because unless it comes out very far, they may not feel it. You might say, well, if they don't feel it, then what's the big deal? Well, the problem is it affects the ability to urinate. It can obstruct the urethra. It causes pressure. And so in many cases, some of the symptoms that patients feel are either urinary tract infections or even I got to go to the bathroom feelings is really from prolapse. And the full discussion of prolapse of the vaginal areas beyond what we're going to talk about today, but there are many methods for treating that. In most cases, it's going to be surgical, and it's generally transvaginal, and the methods that we use today are quite minimally invasive. In most cases, and for example, I've done 4 this week, all those patients have spent the night, and the next day they're gone by 12, and very painless in terms of, for example, transabdominal procedures, and the patients do extremely well in the long run. So I don't want patients to think that this is a big operation like it was maybe in the olden days. In general, it's quite easy. In general, some patients also have uterine prolapse. Now that is where my collaboration with gynecology comes in, because I normally don't do any hysterectomies nowadays, but I have collaboration with the gynecologist. We have our team. So this is really more than just me. This is really a team that involves gynecology and my team of nurses and medical assistants to put all this together. And so I think in the long run, we can generally always get someone better. It's very rare that we can't. Our goal is to improve the quality of patients' life as minimally invasive as possible by affecting them with as least medications and as little surgery as necessary to improve their quality of life and get them back to their normal life.